You clock in for your shift, call up the electronic chart, and see 3 simultaneous high-alert medication orders for a patient with a pulmonary embolus, an IV bolus, a continuous drip, and subcutaneous heparin. Standing in front of that IV pump, you are facing a high-stakes clinical challenge. Safely managing this load begins with correcting a persistent misunderstanding. Heparin does not dissolve or break down existing blood clots. If a massive clot is already blocking a vessel in the lungs, heparin lacks the chemical ability to dissolve that blockage. It prevents existing clots from expanding. Heparin works by binding to a naturally occurring protein in the blood called antithrombin 3. When heparin walks into this protein, it accelerates its activity 1,000-fold, rapidly shutting down the clotting cascade. This graph illustrates the 2 different IV delivery methods. The IV bolus is a heavy loading dose designed to reach a therapeutic state within minutes. Because the liver and kidneys clear heparin out of the body very quickly, the drip acts as the cruise control to maintain that level over the next few days. Accuracy is vital because these orders are strictly weight-based. If you use the patient's weight in pounds instead of kilograms to program the pump, you will calculate a dose for someone who weighs over double the actual patient, risking a fatal hemorrhage. To prevent these errors, hospitals mandate a strict independent double check. A second licensed nurse must walk into the room, perform their own math from scratch, and verify the pump settings before you hit start. Mastering these mathematical mechanics and understanding the drug's physiological limits transforms a high-alert risk into a safely controlled, life-saving tool. Once the drip is running, nurses monitor the risk of hemorrhage using the aPTT lab test. This is the primary dashboard metric, measuring the exact time in seconds it takes for a fibrin clot to form in a test tube. This gauge displays the therapeutic target. A healthy person without anticoagulants forms a clot in about 30 to 40 seconds. For a patient on a heparin drip, the sweet spot is usually 60 to 80 seconds, roughly 1.5 to 2.5 times the baseline. Nurses titrate the drip rate to keep the patient secured in the screamed zone. Even with perfect lab values, dangerous bleeding is often insidious. During oral care, check the gums for oozing mucosa. In the Foley catheter, watch for pink or red-tinged urine. If a patient is bleeding internally, the vital signs serve as the early warning system. A sudden, unexplained drop in blood pressure, paired with a spike in heart rate, indicates a loss of circulating blood volume. A nurse's primary defense against bleeding is pairing laboratory data with rigorous, physical human assessment. Clinical safety requires looking past the IV pump. The morning labs might show a perfectly therapeutic aPTT, but reveal a dangerous trend. The patient's platelet count has dropped by more than 50%. When this happens 5 to 10 days into treatment, it signals a severe immune-mediated complication, heparin-induced thrombocytopenia, or HIT. The immune system misidentifies the heparin-platelet combination as an invader. Antibodies attach to this complex, inadvertently activating the platelets into highly reactive, sticky landmines. Free-floating platelets plummet as the body consumes its supply to build thousands of vascular microclots. These microclots travel throughout the body, where they can lodge in the lungs as new pulmonary embolisms or completely block blood flow to the limbs. Their required action is immediate. Shut down all heparin exposure instantly. Turn off the drip and notify the provider. While the platelet count is low, a transfusion is typically avoided. Giving new platelets during HIT acts like throwing gasoline on a fire, providing more fuel for the deadly microplots. Surviving HIT requires critical intuition to recognize the central paradox. In this specific emergency, thinning the blood has caused the formation of fatal clots. For standard, non-HIT severe bleeding emergencies, there is an emergency brake available. The specific reversal agent for heparin is protamine sulfate. This medication must be pushed intravenously at an incredibly slow rate, no more than 50 milligrams over 10 full minutes. Administering protamine too fast triggers a massive histamine release. This causes the blood vessels to rapidly dilate, resulting in severe hypertension and cardiovascular collapse. When patients develop HIT and can never receive heparin again, they are switched to alternative anticoagulants. Many of these alternatives were originally synthesized by studying naturally occurring peptides found in the saliva of medicinal leechers. To transition a patient to long-term care at home, we use a strategy called the bridge. Because oral warfarin takes several days to work, We keep the patient on the immediate heparin drip until blood tests confirm the oral pill has reached a therapeutic level. A perfect lab value on a computer screen means nothing if the patient on the bed is physically deteriorating. Clinical safety depends on the physical assessment of the human being.